Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
When you turn on your faucet to pour a glass of water, pause for a moment. What you're about to encounter is one of the greatest public health successes of the last 150 years, and it's in no small part due to the work of a guy from Baltimore. Hi, it's Lindsay Smith Rogers, and today on Public Health on Call and in partnership with the Johns Hopkins University Sesquicentennial Celebration, we bring you a special episode about Abel Wolman, a Johns Hopkins professor and engineer whose work forever changed how we think about water treatment here in Baltimore and around the world. Dr. Ari Goldstein, a physician and our podcast resident, talks with Graham Mooney, an associate professor in the history of medicine and epidemiology at the Johns Hopkins School of Medicine, about Wolman in a conversation that may leave you feeling a bit thirsty and maybe more appreciative of public health. Let's listen.
Graham Mooney, welcome to the podcast. Thank you for joining us.
Thank you for having me.
I want to start off. Our topic for today is Abel Wolman and his work with water sanitation and utilities. But first, we should set the scene. What was the state of waterborne diseases in the 19th and early 20th centuries?
Not very good is the answer to that compared to today. Typhoid in particular, which we're going to talk about in relation to Wolman's work, that was part of a kind of constellation of diseases, water and foodborne diseases, including dysentery and diarrhea, that caused a very large proportion of mortality and morbidity in the US, particularly in urban places, big cities. And so, for example, diarrhea would have accounted for a large part of infant mortality. In cities at the turn of the 20th century, infant mortality could be as much as 150, 200 per thousand live births. So it's very, very high. Today in the US, it's much, much lower. That's in the single digits. And a large proportion of that mortality was caused by gastrointestinal diseases. And typhoid was a contributor to that as well. So it's been estimated that in 1900, probably 1 in 3 of every Americans would have contracted typhoid at some point. If you're interested in the rates, probably about 100 cases per 100,000 people. So it wasn't an insignificant disease. And these water and foodborne diseases, their high rates were very much to do with the quality of the water system and the water supply. Although typhoid would have killed around about 5 to 10% of those infected, it had very much a knock-on effect for later in life. So if you're exposed to typhoid at an early age, people were left susceptible to other diseases. So water purification had an impact on the water and foodborne diseases, but also other diseases as well.
I understand that these waterborne diseases didn't necessarily spare any particular communities. Famously made its way through the White House a number of times, at least suspected. It's something that affected broad swaths of society. Many people in the public health community are familiar with the famous story of John Snow and the Broad Street water pump in London. But aside from that, how much participation prior to Abel Wolman did medical or public health professionals have in the establishment and the operation of various public utilities historically?
That's a good question, because public health today is seen very much as an interdisciplinary field. You have folks coming from all kinds of academic disciplines, practical disciplines, and so on, including physicians. But some of the early public health reformers, you mentioned John Snow. He was actually an anaesthetist. He was an anaesthetist to Queen Victoria, incidentally. But a lot of the early public health reformers that we would call, particularly those involved in the sanitary revolution, which was the introduction of citywide water supplies from the 1830s, 40s, 50s onwards, particularly in Europe. They weren't doctors at all. Many of your listeners may have heard of Edwin Chadwick, who's well known for the sanitary idea, which was the implementation of water systems in UK cities. Well, he was a lawyer. He wasn't a physician. And many of the other people who were involved in the introduction of water and sewer systems were engineers. A lot of the work involved, well, what does it take to flush sewer systems properly? And that involved mathematical calculations, expertise in engineering, expertise in geology and topography, so that you know things like the rate of flow of water out of a city. Physicians were around, but they weren't involved to that particular extent until it became a requirement for cities in particular to have medical officers. And that became a requirement in the UK, mandatory in the UK, not until in the 1870s. But that didn't mean to say that you didn't have folks, particularly physicians, who weren't medical officers or health commissioners in cities before that. But until, I would say, like 1890s, it wasn't really consistent. And the way in which health officers worked was very much not necessarily related to their medical qualifications, because most medical officers did have to have a medical qualification. That was important, obviously. They had to understand diseases, they had to understand the natural causes of diseases, things that actually intervened with diseases, things that helped reduce diseases. But that was only part of what they did. They were very much involved with advocacy. So it was crucial for them, for physicians, to advocate for their communities, usually to politicians, because it was politicians who were providing the resources to build these systems. And they were also important for implementing laws. So when they studied to become medical officers of health, physicians, they did courses on hospital isolation, they did courses on sanitary engineering, plumbing, all these different things. So they became advocates for this, but they also had to implement the laws that were in place. And they were often responsible for making sure that folks' plumbing worked, making sure that if people were illegally keeping animals in their backyard, that was monitored as well. So physicians had a bunch of different influences on the development of public health. And of course, they were generally tended to be very much involved at a higher abstract level in terms of the development of public health associations, federal government positions and state government positions. So they had a lot of influence in many different ways.
And Abel Wolman had a less abstract involvement with the water system specifically. I'd like to talk about how he got involved in that initially and how, if at all, his forebears kind of forged the path, or if he had to forge his own path.
He was born in Baltimore in 1892, Abel Wolman. So he was a local guy, and he earned his degree from Baltimore City College, and he went on to Hopkins, where he did a degree in engineering, and that was when the engineering department first opened. So he was one of the first graduates at Hopkins of engineering. One of the things to say is that he moved out almost straight away into government work. He spent a year in the US Public Health Service, and he was studying the quality of the water in the Potomac River, a local river for those who don't know Maryland. And he became a sanitary engineer for the Maryland State Department of Health. One of his responsibilities there was to go and inspect water and wastewater systems across the whole area. And one of the things that he kind of developed becomes very obvious later in his career is this notion of the integration of water and wastewater treatment. So, water and sewage is obviously connected. You need supplies of both in order to have a healthy city. And so when he was chief engineer of the State Department of Health from the early 1920s to the late 1930s, he developed a lot of these ideas. But also at the same time, he was beginning to be consulted nationally and even internationally. So, he started visiting other cities and advising them on the improvements that they could make to their water systems. He was a chairman of the Maryland State Planning Commission from mid-1930s to the end of the Second World War. He was on the Water Resources Committee of the National Resources Planning Board in the 1930s and 1940s. So he wasn't dealing just with water, he was dealing with the ways in which water was connected to a bunch of other issues relating particularly to urban growth and the management of urban places.
That sounds like a very just stark rise for someone who starts very local. Do we know about what other folks in these industries or in related industries thought about his developments and his work?
Well, reading back, particularly on some of his obituaries and some of the commentaries on his life, this early work was clearly formative in the later work that he went on to do. It was obviously part of his formation of his qualification and his authority to talk about water and wastewater supplies. So he worked for Baltimore, as I said. He was a consultant for the city authorities there. He worked for Maryland. Then he started working for other cities in the US and then internationally. I think that in itself is a commentary on how folks perceived the quality of Wolman's work. They valued his opinion, and he brought all that experience to bear when he was consulting for these other places.
How did he make that jump from specifically US-based involvement to more international work? It seems like quite a big development for someone of his stature.
Well, I think the first thing to note is that in 1919, he published with a chemist, Lynn Enslow, an article. It was actually in the Journal of Industrial and Engineering Chemistry. It wasn't in ostensibly public health journal, although obviously public health people were interested in this. He published an article that established the standards for adding chlorine to municipal water supplies to make them safe. And this was important because other places had started using chlorine. I think New Jersey was the first in around about 1908. But the work that Wolman and Enslow did provided the retrospective evidence for that and for also the standard amounts of application and so on. So that really established his expertise in the area, and he became famous for that initially. And he began working on the Baltimore City's extended water supply and sewage treatment plants in the 1930s. I think the other thing that became important for his international stature was he began teaching at Johns Hopkins in the School of Public Health in the 1920s, the early 1920s. He was a really relaxed teacher, and he had a lot of energy. He was funny, and he was like that until the end of his life. But he saw himself primarily as a practicing engineer. He was appointed professor and chair of two departments, interestingly. The School of Hygiene and Public Health and the School of Arts and Sciences had him as a chair of engineering from 1937 to 61. Obviously, Hopkins Research University, already established as one of the leading public health schools in the world, that raised his profile immensely. So now not just practitioners, but also academics were exposed to his knowledge and work. And he became a consultant to, over time, around about 50 different countries across the world, Latin America, Asia, Africa, where he consulted on all aspects of sanitary engineering. He was a member of the first United States delegation to the World Assembly of the World Health Organization. So already by that point, he's been recognized, and his influence became felt because it's been described by historians that he bullied and cajoled other members of the World Health Organization into making water and sanitation a top priority, which seems strange to us now that he had to do that work to convince them. But he was really adamant that it was important. He was successful there, and after that he made a lot of trips over to Geneva and the World Health Organization. So he was a consultant to the Public Health Service, other international organisations, and he also became, I think he was the president of the American Public Health Association at some point. So all these positions enabled him to have a very wide reach in terms of how he became an international globe-trotting consultant in terms of water and sanitary engineering.
Speaking to his work around the world, these middle decades of the 20th century were a time in this sort of work that, especially looking back on things, were somewhat fraught in terms of how people approached international development work. So I'm curious how his work was distinguished from the typical work that was being done in this realm at the time.
The transference of knowledge is really important in this context. What Wolman was doing was effectively bringing the knowledge and his expertise into these other countries in the global south. So one of the things that is kind of important in that respect, in terms of the knowledge, is that some of the stuff in relation to utilities and the introduction of utilities it's important infrastructurally, but it takes a lot of investment. However, on the other hand, chlorination itself isn't particularly cost intensive. So there are other ways in which chlorination, filtration can be introduced that don't involve massive investments in infrastructure. And I think that's kind of the case now. Some of that is recognised now in the present.
So Abel Wolman did all of this work in Baltimore, in the United States, all around the world. What do we know about the results of his work, both tangibly and intangibly?
It's easiest to see this in terms of reductions in mortality and morbidity. So in the early 20th century, as I mentioned earlier, the rates of morbidity, case fatality rates, they were quite high compared to today in the US. But once cities introduced not just chlorination but filtration as well, filtration was a development before chlorination, waterborne diseases began to decline quite sharply. And historical epidemiologists and economic historians have calculated that clean water was responsible for about 40-45% of the total mortality decline in large US cities between 1900 and 1936. Now, we can be sceptical about the kind of precision in terms of percentages and so on, like that when you're calculating contributions to mortality decline, but compared to other contributions, that's really important. Historians have estimated that infant mortality dropped by about 50 to 60% because of clean water as well. So very much responsible for eradicating typhoid in the US, almost anyway, by the Second World War, which is pretty remarkable, a remarkable contribution. And like I say, it's not just chlorination, it's filtration, it's efficient systems, and so on. But tangibly, very, very important. Perhaps less tangibly, first of all, is the importance of water and sanitation as central to health. I know that sounds a little anachronistic in the present context, but he himself said that he had to absolutely work really hard to put this on the agendas of local, state and international bodies. And I think that is another key thing about Wolman, is how he worked across scales. Really impressive that we talked today about the local and the global, and there are problems with that kind of dichotomization. And Wolman shows that. He shows that by working not just at the local and what we call now the global, but in the in-betweens as well, can be really important and really effective. So that's kind of another intangible thing. He was one of the first non-MDs to be president of the American Public Health Association. He wasn't the first, but he was one of the first. He got an honorary doctorate of engineering in 1937. So that is also important. We do think of public health as being this interdisciplinary field, but it took a lot for non-physicians to get involved at those very high levels, those influential levels. He became the editor of the American Journal of Public Health, or associate editor, editors of the American Waterworks Association, and so on. So they're kind of like data points that say he was important, influential, but the way in which we know how professional societies work, a lot of it takes place in the background. A lot of it is unseen and unheard, and it's very difficult to imagine that Wolman wasn't as important and persuasive in these associations in the same way that he wasn't important in his consulting work across the world. Another intangible, I guess, is that, first of all, he lived a long life. He was 96 when he died in 1989. The longer life you have, obviously, you make an impact. And he didn't stop when he retired. He continued until very late into his life. He was actually voted one of Maryland's most important citizens of the 20th century. That acknowledges that scale of work. He did a lot of work locally, but also internationally. And I think that's kind of another intangible way of thinking about that local folks thought of him as a local boy, made good, if you like, made brilliant, in fact, and that they chose to recognise that. And that speaks to both the tangible and intangible, I think.
Yeah, I mean, I definitely think you can see the echoes of everything that he did in the scaling of his work, in the interdisciplinary nature that you talk about, how conscientious and detail-oriented while still being human-centered, which I think is definitely huge. This episode is part of the Johns Hopkins 150th anniversary celebration. And so as part of that, we're trying to understand, looking back at the last 150 years, what can we take as we're moving forward into the next? So I'm curious if there are public health professionals listening, students, prospective students in the public health sphere, what lessons should they take away from looking at Abel Wolman, this person famously nicknamed Friend of the Thirsty?
Yes, yeah. Well, a couple of things, I think. First of all, simple interventions can have a massive effect, and we know that. Chlorination is a relatively simple intervention, but it can have an impact on people's immediate health, their future health, and population level, the health of communities more broadly. So I think simple is often good. And the other thing for me is the way in which we think about the role of water and sanitation as a public health enterprise. One of the things that Wolman did, I think it was in the 1950s, he published a really influential article called The Metabolism of Cities. And his argument was that we have to see cities as having inputs, throughputs and outputs, and we have to think of those holistically if we are to devise interventions that have an impact on whole communities. So I think what he's fighting against there is the idea that, for example, you have a sewer system, and originally a lot of sewer systems just took water away and dumped it in the ocean or on farmland and had deleterious effects further down the line. What Wolman was arguing is that you can't think of it like that because it's a cycle and it comes back into the system. And so thinking about all these things together, how stuff gets into a city, what you do with it while it's there, and then how that cycles back round to coming back into the city is really important. And I think that holistic approach is something that public health practitioners today are encouraged to think about, but it's not always easy to put into practice. But a lot of those conceptual ideas were shaped by Wolman's approach to water and sanitary engineering.
Dr. Graham Mooney, thank you so much for joining us. I'll be certainly mindful of everything we discuss when I turn on the faucet later today.
Yeah, and when you drink that water.
Yes, absolutely. Thank you.
Thanks for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.